Ladies and gentlemen, thank you for standing by. During this seminar, all participants will be in a listen-only mode. There will be a question and answer session at the end of the presentation using questions submitted through the Q&A feature. We cannot answer questions about individual medical situations during the seminar. We will attempt to answer as many questions as possible at the end of the presentation. As a reminder, this presentation is being recorded for replay purposes. Welcome to New Treatment Options for Advanced GIST and Concerns about the Coronavirus. Please remember the information provided in this web seminar is not intended as a substitute for your physician's guidance and care. My name is Sarah Rothschild, the Allergy VP of Program Services, and I am your moderator for today. I would like to introduce our presenter today, Dr. Michael Heinrich. Dr. Heinrich earned his medical degree from Johns Hopkins School of Medicine in Baltimore and completed both his residency training and fellowship in hematology medical oncology at Oregon Health and Science University. Dr. Heinrich's research, like much of the work at the Knight Cancer Institute, revolves around a basic yet complex premise. You have to understand what is broken in order to fix it. That's why Dr. Heinrich is intently focused on identifying the molecular targets that cause cancer, which is essential to the development of better and less toxic therapies. He's recognized internationally for groundbreaking research discoveries that have improved care for patients with GIST, and his research has implications for many types of cancer. Before we get started on the topic of new treatment options for advanced GIST, we had a number of questions that came in concerning the coronavirus, and Dr. Heinrich was kind enough to spend some time today to answer these questions. Please note that it's still important for you to check with your doctor about any questions that you have about your individual care. To start off, with the first question, what do GIST patients need to be aware of about the COVID-19 virus?
Good morning or good afternoon to everyone. It's a pleasure to participate in this. So, in many ways, GIST patients are like everybody else, that everyone is susceptible to this virus because we haven't seen it before. And so social distancing, limiting social interactions are important. It is unclear whether the therapy such as Avapritinib for GIST would cause people to be more susceptible to the virus. We don't have strong evidence either way on that. But we would say that since many GIST patients are older, or patients might have other medical problems or be ill from their cancer, that they're at risk of having more severe cases. And so again, social distancing, trying not to get the virus, are important for GIST patients and cancer patients because they are in a susceptible population.
Thank you. The next question is, can I still take my medication, my GIST medication?
Yes, you should continue to take your GIST medication as recommended by your doctor. If you have advanced GIST, you're much more at risk of that actually than of coronavirus in terms of threatening your lifespan. Even if the adjuvant setting, when you've had surgery, we view, if your doctor recommended adjuvant Avapritinib, that still is an important part. So we're not telling, cancer patients to stop the therapies. We're not telling heart patients to stop their heart therapies. You need to listen to your doctor and take therapy. We don't see a reason to not do that.
Okay, thank you. A couple questions came in. If I'm going for follow-up treatment, should I still go? Should I cancel my doctor visits? What about my scans? What are your thoughts on that?
Yeah, so what we're doing at our cancer center is we're looking, week by week at all the appointments and deciding which visits could be done by phone. So we're doing most of our follow-ups by phone. If people need a scan because for example, they've just switched therapies, then they still need a scan. But we sometimes have people come, get their labs, get a scan, go home, and then we talk to them by phone. In situations, for example, surveillance, like you would do for an annual scan, given the circumstances, we would probably talk to you by phone and say, well, maybe just delay your scan by a month or two until everything, potentially settles down. So we're trying to do everything as much as we can by phone. and trying to limit kind of unnecessary visits to our medical center. We are not closed. We will still see you if you're sick. We are still having an infusion center doing transfusions and chemotherapy for other cancer patients. So we're just trying to limit as much as possible people needing to leave their home.
A big question that keeps being asked, is it safe for me to take pain relievers? And what fever reducer, if needed, is safe for a GIST patient?
Yeah, so there's controversy about this, about there was something suggested that ibuprofen might be dangerous compared to acetaminophen or Tylenol. We don't really know that that's true. If you wanted to be conservative, you could take Tylenol or acetaminophen. Historically, we've said for people on Gleevec that they should avoid Tylenol, but I think a lot of that was from 20 years ago from people who had very advanced leukemia, who had bad things happen to the liver when they took Tylenol, and may not have been anything to do with the Tylenol. So if you take less than 4 extra strength Tylenol per day, then your liver will be fine. And that's probably the safest fever reducer. But people with arthritis or gout or things, we're not telling them not to take ibuprofen. So, in the case of fever, you have a choice. In the case of arthritis, you might not have a choice.
Thank you. Another question that's being asked is it true that Gleevec may help boost immunity to the virus? And then another question was, there's a Lancet paper that says sunitinib could inhibit advances of coronavirus. Would this be accurate? People under sunitinib would be protected.
Yeah, so there's been quite a bit of debate about that. For example, in Italy, there was a statement saying that people with CML on imatinib, that no one had gotten coronavirus. But if you did the math on how many people in Italy have CML and how many people had got the coronavirus, it was unlikely that you would have seen even one person with CML anyway. There are some older papers. I'm not familiar with the Lancet paper. There's some older papers saying that imatinib might be useful against coronavirus, or at least the original SARS virus. But those papers were very poor science. They were using incredibly high doses of imatinib in a test tube. So that would be the equivalent of saying, well, if you took 100 Gleevec tablets per day, you might be fine, but you wouldn't be fine because that would probably kill you from the Gleevec. So we don't really have any evidence one way or the other that it's either harmful or protective.
Okay, thank you. If a GIST patient has some symptoms such as sore throat and low-grade fever, should you call your PCP who isn't very familiar with GIST, or you should call your GIST oncologist? Can either one have you tested for COVID-19?
Yeah, well, that's a good question. So I guess, it's whoever you have the closer connection to. Some people who are GIST patients might see their GIST, doctor 12 times a year and see their PCP once a year. It depends on where you live and what the current guidelines are. Originally we didn't have a lot of capacity to do testing, and now that's being built up. But now the problem is that everybody who gets tested, the person who tests you has to be fully gowned up and masked up because putting a swab in your nose is likely to make you cough or sneeze, which if you actually had the virus would spread it. And for every person to be tested means you have to consume all of that personal protective equipment per patient, because you can't use the same gown to go to the next patient, because then you would be spreading the virus. And so places like New York and Seattle, I think, that are under the gun are now limiting testing to people who need to be hospitalized, or for healthcare workers or first responders, because they don't have enough masks and gowns to test everybody that probably should be tested. So you would have to, look at what your local public health authorities are saying and talk to your physician and see what's possible. It's an evolving subject. Before we didn't have enough tests, now we do, but now we don't have enough equipment to test people, so that's a problem.
Okay, thank you. So for the audience, we're going to actually transition to the presentation about new treatment options. And at the end, if there are other questions that come in that people want to ask about coronavirus, we'll leave those questions to the end. Okay, so Dr. Heinrich, you can go ahead and begin your presentation.
Okay, so it's my pleasure to talk about new treatment options for GIST. It's an exciting year as things are emerging and developing, and we'll go through some of the advances, what we know, and then also what we don't know in terms of what's going to happen in the next couple of years. So did my slide just advance? Let's see.
Yes.
Okay, so these are my disclosures and conflicts of interest that I'm required to report. And what we're going to talk about today is development of the new kinase inhibitors for GIST. We'll talk a little bit about the background, why do we need these things in the first place, and then we'll talk about the new agents, Avapritinib, formerly known as BLU-285, or Ripretinib, formerly known as DCC-2618. And so just by way of background, as is well known to this audience, prior to the development of kinase inhibitors, there were no treatment for GIST. And once we developed agents such as Imatinib, Sunitinib, and Regorafenib, that's completely transformed how we treat the disease because these are the only effective therapies. However, as is also well known to this audience, that it is possible for the GIST tumors to mutate and get drug-resistant clones. And over time, the battle as we switch from drug to drug to drug is to be able to control those clones. And so in order to understand the landscape and the new medications, I want to introduce three concepts which I'll review in the context of the new drugs. So the first concept is pretty familiar to a lot of the audience, that drug resistance is commonly due to the development of secondary mutations in the disease-causing mutant kinase. So if you have KIT exon 11 mutant GIST and your tumors become resistant to Gleevec, that's because there are secondary KIT mutations that arise, and we'll review that. The second concept was prior to this year, all of the agents that we use for treatment of GIST bound to the inactive kinase structure, and I'll review what the inactive kinase structure, what that phrase means, and that's important because now we have an exception to this rule, Avapritinib, which actually binds to a different kinase structure. The third concept is that, prior to this year, or even now, all of the agents that we use for treatment of GIST that are approved are competitive ATP inhibitors, and I'll discuss what that phrase means. But the exception to the rule now is Ripretinib, which is not a competitive ATP inhibitor. So the first concept is that drug resistance is commonly due to the development of acquired mutations in the disease-causing mutant kinase. So as is well known, Imatinib is a frontline therapy, so the chemical structure on the left and the progression-free survival shown on the right. And Sunitinib is the second-line therapy. Regorafenib is the third-line therapy. And I have the really small view of the slides. I guess I can make that bigger. But what's notable is that in the case of Imatinib, the time axis on the x-axis is in years, whereas when we get to second-line therapy with Sunitinib or Regorafenib, the x-axis becomes weeks or months. And the reason for that is shown here. So this is a cartoon showing the KIT molecule. We've boxed in the what's called the kinase, which is the enzyme portion of the molecule on the inside of the cell, and then exploded it up so we see exons 13, exons 14, exons 17, exons 18. So the blue boxes are what's called the ATP binding domain, and the green boxes are what's called the activation loop. and we'll come back to both of those concepts. When we look at drug-resistant GIST, then we see that there are certain recurrent mutations that are seen. So in exon 13, we see the V654A mutation. In exon 14, we see T670I. And then in exon 17, there's a variety of different mutations. If you go to the far right of the slide, where we have sort of this traffic light view, red boxes mean that this mutation is resistant to the drug. So IM is imatinib, SU is sunitinib, reg is regorafenib. So if you look at the column of imatinib, you can see that for all of these mutations, it's either resistant or has intermediate resistance, shown by the yellow boxes. When we switch to sunitinib, we see that we turn the exon 13 and exon 14 boxes from red to green, indicating that tumors with those secondary mutations would respond to sunitinib. But what you see down looking at the exon 17, exon 18 situation is that the boxes remain red. And so one of the reasons that sunitinib has such a short duration of activity on average compared to imatinib is that sunitinib can only work against some of the secondary mutations. So in patients with exon 13 and 14 dominant drug-resistant clones, then sunitinib would be highly active. In patients who have predominantly exon 17 mutant clones, then sunitinib will have no activity. Most patients have a mixture of them across different tumors, and so it's typical to see sort of a mixed pattern of response. But on average, if some of the disease is intrinsically resistant, it's hard to get a long duration of activity because those tumors are just going to grow from the beginning. If we switch to our third-line therapy with regorafenib, we kind of flip the script compared to sunitinib. So the exon 13 and exon 14 disease control is lost, but we pick up some but not all of the exon 17 and 18 mutations. So again, we have the problem of that if you had predominantly exon 13, 14 disease, rego is not going to work. If you have predominantly exon 17 resistant mutation, rego has a better chance of working. But again, it's quite typical for patients treated with sunitinib or regorafenib to have mixed responses to therapy. So the second concept is that prior to this year, all of the approved GIST kinase inhibitors bound to what's called the inactive conformation. So this is a view of the KIT protein in what's called a ribbon structure. And pay attention to the purple part of the protein. That's the activation loop. So in the inactive conformation, the purple loop is to the left, as it is here. And what's shown in yellow is imatinib. So imatinib fits in there kind of perfectly into this tight little space and can inhibit KIT. But on the right panel, when the activation loop in purple moves to the right, you see that the purple part and the yellow imatinib are occupying the same space, and that's physically impossible. So, I can put my hand above my desk, but I can't put my hand through the desk. So the same thing happens with the protein. The protein occupies space, and the drug can no longer fit, and so it can't bind, and therefore it can't work. And just to show what the problem is with resistant tumors, so again, this is looking at the inactive conformation on the left. In this case, the activation loop is in green, not purple, and the activated form of KIT on the right panel. And I highlighted with a star an activation loop mutation, such as an exon 17 mutation. And so those mutations stabilize the protein, so it wants to always have the activation loop to the right. And that's the shape of the protein that imatinib cannot bind to. However, the scientists at Blueprint Medicine were able to overcome this. So this is Avapritinib, or Blue 285 formerly, shown on the left. you can tell it's the active conformation because the purple loop is to the right, and the Avapritinib fits into this space, whereas, as I showed you before, Imatinib cannot fit into this active conformation. And so realizing that these exon 17 mutations were not very effectively drugged by the agents that we had now, this led to the design of Avapritinib. So I want to now go through some of the data regarding Avapritinib. So the first study of Avapritinib was what's called the Navigator phase 1 study, in which patients started at very low dose, and then we continued to escalate the dose to find what we thought would be the optimal dose. And then we moved forward with that dose in 3 cohorts. The PDGFRA D842V, which actually led to the approval of this agent, and some other cohorts in 3rd line, 4th line, or 2nd line treatment. Just to review the PDGFR alpha exon 18, this is what's called a waterfall plot. So what we're looking at, each bar represents an individual patient. If the bar goes up, as shown on the 2 bars on the far left, that means that the tumor did not respond and grew during therapy. Whereas the bars on all the other bars that are going downward show that the tumor is getting smaller. If it goes all the way down to minus 100, which is the 1, 2, 3, 6 bars on the far right, that means a complete response, that there was no visible tumor. The horizontal bar at minus 30 is what we would define objectively as a partial response. In the box on the right of this slide, we see the overall response rate was 86%, which means people had a partial response or a complete response. The clinical benefit rate, which is every response other than progression, was 95%. Impressively, 7% of patients had a complete response, 79% had partial response, 12% had stable disease, and only 2% of patients had progressive disease. Just to show an example of this, this is a patient before treatment on the right. Most of the abdomen is filled up with a very large GIST tumor, indicated by the red arrows. After treatment, 1 year treatment, then there still is a much smaller tumor, which is a very small fluid-filled collection of necrotic junk. This was not only an impressive radiographic response, but the patient at baseline, I couldn't actually show you the baseline scan because she was unable to breathe because she couldn't lay flat in the CT scanner because she couldn't breathe because of the size of the tumor. She had to kind of lay at a strange sideways angle. So it was quite impressive to see how much she improved very quickly and to see her overall response evolve. If we look at how long does this last, and the answer is, well, we don't really know. So in oncology, we generally try to define the median, which is the 50% time point. So a median progression-free survival of, say, hypothetically 12 months means that half the people's tumors progress before 12 months and half the people progress after 12 months. But in order to find the median, you have to have the progression happen to at least 50%, and that hasn't happened yet. So we are out to almost 2 years, and still more than 50% of patients are still having disease control and haven't progressed. So that is similar duration-wise so far as to what we would see in the front line if we used Imatinib to treat KIT exon 11 mutant GIST. The other major population of interest in the study was the patients treated in the 4th line or later. And as you can see here on the waterfall, there were a number of people that responded, but also there are more patients who don't respond to this agent because there's more bars that go up on the left side. Overall, the response rate was 22%. because the PDGFR alpha D842V mutant patients have a more higher likelihood of response, if you subtract out those people, so you're looking at the KIT mutant patients, there still was a 17% overall response, which is still higher than what we saw in the second line with sunitinib or in the third line with regorafenib. In the box on the right, the overall response rate was 22%, and the clinical benefit rate was 41%. If you ask the question, if you're responding, how long does it last? Then in these patients, which still was a small number of patients, only 23 total, the median duration response was 10 months. So if you respond, it's likely to be reasonably durable. Shown here are side effects for the usual doses that were used in the study, which is 300 or 400 milligrams. So they're broken down. AE stands for adverse event. Treatment-related means that a side effect or a symptom developed and we thought it was due to the drug as opposed to just having GIST or some other medical cause. And then we break things down by all grades, meaning any severity, whereas grade 3 or higher are generally more severe side effects. And so, as is typical for a lot of kinase inhibitors used for GIST, nausea, although generally mild rather than severe, fatigue are common. Anemia is common, but it's more unusual to have grade 3, which would mean you probably need a transfusion. So there's a higher rate of needing a transfusion with Avapritinib using this dose. Other things, periorbital edema, etc., are kind of similar. The one thing that's on here which is the fourth one, which is cognitive effects. So cognitive effects this term is kind of vague because it's hard to describe exactly the symptoms, and so this is pulling together what some investigators would call memory impairment, some would call it a cognitive disorder, some would call it a confusional state, some patients would call it encephalopathy. These can be quite subtle in some patients, and so the patient may not be aware of these symptoms, but a spouse or significant other or friend or relative would be more easily aware of these things. And so as this agent goes forward, and now that it's approved, it's be important for physicians to become familiar with these symptoms. So they can be quite mild in terms of, losing your car keys, but losing them 5 times a day instead of your usual 1 time a day, mild word finding, difficulties, forgetting people's names even though you know everything else about that person, sometimes forgetting conversations or forgetting appointments. And so when the symptoms are mild, they can be easily managed by either reducing the dose or what we've done more recently is just to give patients brief treatment interruptions like 7 to 14 days. The symptoms can be more severe in people, especially if you don't intervene early and you let the symptoms kind of increase in severity. The symptoms generally don't onset from day 1 of therapy, so it generally takes, depending on the dose, takes weeks or months for them to onset. With a week or 2 off, most people reset pretty significantly to a baseline. But it's something for patients to be aware of and caregivers to be aware of as well. There's not a great test that we can do for this, like nothing shows up on a scan. We've tried, written tests to people, but it doesn't really seem to capture what's going on. And I could take questions on this at the end. So these are the ongoing studies. So the Navigator study is what I just described, and below is the Voyager study, which is a randomized phase 3 study, which is in the third line comparing Avapritinib to regorafenib. This study is fully enrolled as of last fall, and we coronavirus notwithstanding, expect to know the results of the study sometime in the next several months. Avapritinib is now approved, and so this is what's called the package insert. So the FDA for all drugs makes an approved package insert, which in the old days would physically be a piece of paper that if you opened your pill box, or if you opened a box that had a bottle of pills, this would be what's in there. This is the approved prescribing information for a U.S. physician. So the first part of it is always, what is it supposed to be used for? So the name of avapritinib is now Avakit, is a kinase inhibitor indicated for treatments of adults with unresectable or metastatic GIST harboring a PDGFRA exon 18 mutation, including PDGFRA D842V, which is the most common version of this. Then the next thing it tells you is that you should select patients for treatment based on knowing that they have a PDGFRA exon 18 mutation, and the starting dose is 300 milligrams daily taken on an empty stomach. The next thing the FDA usually tells you is what are the more severe or special side effects of the drug. So intracranial hemorrhage is seen in a very small percent of patients, and gives recommendations for that. The CNS side effects, which I just talked about. And then, as with most cancer agents, we really don't know if it's safe to take when you're pregnant, and so we want people to not be getting pregnant if they're taking this agent. And then the FDA always lays out the adverse reactions. So the most common adverse reactions, according to the FDA, are edema, nausea, fatigue, cognitive impairment, vomiting, decreased appetite, diarrhea, hair color changes, increased lacrimation, abdominal pain, constipation, rash, and dizziness. So it's sort of a long list, although if you look at any kinase inhibitor, it would have a list at least this long. One thing that I wanted to highlight, which is well known to this audience, is that mutation testing is super critical. And so our colleague John Trent down at University of Miami did analysis of almost 4,000 U.S. GIST patients diagnosed in the 2010 to 2015 time period, and found that overall only 27% of these patients had mutation testing. And we would have thought that, well, maybe at least the patients with metastatic disease would have more testing, but in fact that wasn't true. It still was around 27%. However, there was an association that if the patients who had mutation testing actually had a reduced risk of death, probably because they were getting better treatments. So the point of this slide is that avapritinib is now approved for exon 18 mutant GIST, but if you don't know you have exon 18 mutant GIST, you're not going to get prescribed the drugs. And currently, if the trend that Dr. Trent observed held up, that means that 73% of patients in the United States who would benefit from this drug would not be identified. And so, drug cost is always an issue. There is a patient support program called Your Blueprint. And so this is shown here. This is a slide from the company. It tells you a little bit how to enroll. There's a website. And so there is both copay assistance and then even free drug if your insurance doesn't cover avapritinib, or at least that's my understanding of it. And so if you are a candidate for avapritinib, then this is your kind of source or your access to the patient support program. So future directions. Well, right now, avapritinib is approved for PDGFRA exon 18 mutant GIST at any line of therapy. The FDA is currently considering whether or not the fourth line and later patients will get approval for avapritinib, which would approve it for being used in any GIST, predominantly KIT mutant, in the fourth line or later. The Voyager study, which is the third line, fourth line study for people who never had regorafenib yet, of Avapritinib versus regorafenib, should have results in the next several months. And if it was a positive study, that is, Avapritinib was superior to regorafenib, then that would lead to approval in the third line, fourth line, rego-naive setting. In the future, there may be a second line study, and that had previously been announced or discussed, but not as much discussed lately. I think it all depends on how the Voyager study comes out. The third concept would be that even counting Avapritinib, all of the approved TKIs used for the treatment of GIST are what's known as competitive ATP inhibitors. So KIT is sort of a machine. It does something. It's an enzymatic. It performs a reaction, which is known as the kinase reaction. So like many machines, it needs a power source. And so it turns out that ATP is like the battery pack that drives or allows KIT and PDGFRA to be active. And so you can imagine that there's a little battery pack in the KIT molecule. And so what the current drugs are doing is that they are in the same shape as ATP. So it's like a mimic battery that you put in there that doesn't work. So you can think about your cell phone. Your cell phone has a battery. If you took out your cell phone battery and put in a piece of cardboard that was exactly the same shape and size as your cell phone battery, it would not work. And that's what imatinib, sunitinib, regorafenib, and Avapritinib do. They bind into the kinase where the ATP battery pack is supposed to go, but they don't provide any energy, so they just sort of kill the machine. And that's true both for Avapritinib and imatinib. They just, as we discussed before, bind to different structures of KIT. And so really in terms of inhibiting KIT, there's sort of two strategies. One is you can block the ATP binding, and the class is known as competitive ATP inhibitors. Examples would include imatinib, sunitinib, regorafenib, and now Avapritinib. The other strategy is to prevent the activation loop from moving into the active position. So in that loop that we talked about that was purple or green, depending on the slide, it has to move from the left to the right in order for the kinase machine to work. And so one strategy would be to physically prevent that activation loop from moving. And so that class would be known as a switch pocket inhibitor. And our first and only example of that thus far is Ripretinib, which was formerly known as DCC 2618. And so now I'm going to show a little video, hopefully, of how this works. I think I'll show that one more time. physically blocked. So the major study of Ripretinib is a study known as Invictus. So this is kind of a complicated scheme of how it works. But really, we're just going to focus on this stuff that's been expanded out. So this is a randomized phase 3 study. This is just patients with either KIT or PDGFRA mutant GIST and a few wild types, but not that many. Patients were being treated in the fourth line or later, and patients were randomized to either get Ripretinib or placebo. This is what's known as a double-blind study, so the physicians and patients don't know, neither the physician nor the patient knows what therapy they're getting. When people have scans, they're sent off to a central place in which those radiologists don't know who anybody is or what they're taking, so in a way it's sort of a triple-blind study. The patients, the physicians, and the radiologists are all blinded. If there's progression, then we unblind and figure out what patients were on, and then patients on placebo could cross over and get Ripretinib. This is the baseline characteristics, which are pretty typical for advanced GIST. I think the important part for the audience is if you look down at the bottom, the KIT mutations made up 77%. There were a few PDGFRA. There were some patients that it wasn't done or the analysis failed. And only 8% of the patients actually had what we would historically called wild type, but they didn't have a KIT or PDGFRA mutation. It's not specified what else they might have. This is the sort of take-home message. So this is the progression-free survival. So in these kinds of curves, we start at time 0, which is when patients started treatment. 100% of people haven't had progression because we just did a scan and that's the baseline. And then over time, we do scans as people continue therapy. As the curves go down, that means that a patient has had progression. So if we start with 100% of people at the top not having progression, if the curve goes all the way down to the x-axis, that meant everybody progressed. So the curve of patients taking Ripretinib is the top curve, which is the red. The patients taking placebo is the gray curve. And you can see that the average time to progression while taking Ripretinib was 6.3 months, and the average time taking placebo was 1 month. To put the 6.3 months in context, 6.3 months is about what we see with Sunitinib in the second line. In the third line, Regorafenib in a similar design study had 4.9 months of progression-free survival. So it's quite impressive using a drug in the fourth line that we're getting better results in the third line and arguably similar results than what we saw in the second line. This also reduced the risk of death if you were taking Ripretinib compared to placebo. And as further evidence that the drug is active, what's shown here is 3 groups. The top group in red are the patients who are taking Ripretinib from the get-go at the start of the study. Patients in the intermediate bar, which is I don't know what you call that, khaki, I guess. Those are patients who started on placebo and then were crossed over to Ripretinib. And the green bars that go down are patients who never progressed. And so in the study, if you got Ripretinib after you progressed on placebo, it improved your survival, whereas if you never crossed over and never took Ripretinib, your survival was very poor. And you can see over here in the box above the curves, the mean overall survival for patients who are on the Ripretinib was 15 months. If you started on placebo and crossed over, is 11.6 months. And if you were on placebo but never got to Ripretinib, generally because you got too sick and couldn't continue the study, then the median survival was only 1.8 months. Shown here are what's called treatment-emergent adverse events. What's interesting in this table is that because there's a placebo arm, you can actually figure out, what symptoms are due to the drug potentially versus the disease. So if you look at abdominal pain, it's quite similar between placebo and Ripretinib, suggesting that abdominal pain is probably from the tumor. Some things are definitely more common with Ripretinib, which includes alopecia, what we call palmar plantar erythrodysesthesia syndrome, or hand-foot skin reaction, was seen in a minority of people, although not in severe grades. So this is a pretty typical list of side effects from a kinase inhibitor. If you look at the ones that were severe, then the rate of severe side effects that were felt due to the drug is actually the same between placebo and Ripretinib, again indicating a lot of the severe side effects were potentially due to the disease, not necessarily the drug. If you look at what kind of side effects led to dose interruptions or dose reductions, the rate was rather small, and the rate of discontinuation of the drug, meaning that it just couldn't be tolerated no matter what we did with it, was very small for Ripretinib. So the conclusion of Invictus was that the median progression-free survival was improved with Ripretinib. The risk of progression or death was reduced 85% compared with placebo, and that Ripretinib had a favorable tolerability or side effect profile. So the FDA is currently considering data from this study known as Invictus and will likely approve Ripretinib for the treatment of KIT and PDGFRA mutant GIST in the fourth line or later. Currently, the company is also conducting a study known as INTRIGUE, which is comparing Ripretinib versus Sunitinib for second-line patients. Before all of the COVID-19 activity and the world change, we thought that this will likely conclude enrollment in 2020. Now that seems less likely. We hope to get results in 2021. We hope that's still true. If this study shows Ripretinib is superior to Sunitinib, it would lead to the approval of Ripretinib as a second-line treatment. So to conclude, I wanted to review how things are changing and how they may change, because I think we're headed for a little bit of a confusing time as we get two new agents approved. So currently, as of last year, it was pretty straightforward. First line Imatinib, second line Sunitinib, third line Regorafenib, fourth line nothing is FDA approved, fifth line nothing is FDA approved. As of this year, it changed because Avapritinib became approved for exon 18 mutant GIST, and so that's the second row, where Avapritinib really should be used at any line of therapy, ideally the earliest line of therapy that you identify a PDGFRA mutation, especially PDGFRA D842V mutant GIST, which we wouldn't expect to approve to respond to any agent, so we should lead with Avapritinib. So that's a little confusing because now we have a new drug, but at least it's pretty clear that we would use it for exon 18. But what is likely to happen come June, assuming that everything continues, is that Avapritinib and Ripretinib both may get approved for the fourth line. So then things start getting confusing because you could do Imatinib, Sunitinib, Regorafenib, then do Avapritinib in the fourth line and have Ripretinib be your fifth line. Or you could do the big three, Imatinib, Sunitinib, Regorafenib, and then do Ripretinib for the fourth line and Avapritinib for the fifth line. So then we don't really know which of these strategies is the best. And then Avapritinib would still be the agent used for PDGFRA exon 18. But then as the Avapritinib study gets reported, then it depends on whether or not it beats Regorafenib. So if it doesn't beat Regorafenib, it would be Imatinib, Sunitinib, Regorafenib Avapritinib, then Ripretinib, or Ripretinib versus Avapritinib in the 4th and 5th. But if Avapritinib now becomes the 3rd line, then it simplifies the 4th line because it would be Ripretinib, but then we wouldn't know what at all to do in the 5th line, although maybe we would recycle Avapritinib. And then to further confuse things, next, or a couple years from now, Ripretinib might get approved for the 2nd line, so it would be Imatinib, Ripretinib, Regorafenib, Avapritinib, and then do we recycle Sunitinib? We'd have to test that. Or it could be Imatinib, Ripretinib, and Avapritinib in the 3rd line, and then the 4th line would be, who knows, maybe Sunitinib, and maybe 5th line Regorafenib. It's not clear. Rego doesn't do anything that the other drugs don't do. So my sense is that Regorafenib would not be very active after these agents. Sunitinib at least is really active against exon 13, 14, and that is something that Avapritinib and Ripretinib might struggle with. So Sunitinib may still have a role, but we have to define it. To summarize then, Avapritinib is now approved for treatment of PDGFRA exon 18 mutant GIST. Both Avapritinib and Ripretinib are likely to be approved this summer for 4th line and later. Ongoing studies may lead to approval of Avapritinib in the 3rd line and Ripretinib in the 2nd line. But again, as with any talk about treating GIST, make sure you know your foe. We need to have patients mutation tested. We've been saying that for years. Now there's a critical reason. We need to identify patients with PDGFRA exon 18 mutant GIST, and we need to make sure they get Avapritinib. So with that, I will conclude. This is our #SlayGIST, which is something that our GIST team came up with at a beach retreat. And so we try to keep that in our minds at all times. And I'll turn it back to Sarah, I guess, to moderate.
Thank you, Dr. Heinrich. I wish that we had a beach retreat. I'll put in the word to Norman. So thank you so much for this presentation. Lots of information and a lot of great questions that came in. It's pretty impressive, some of the questions that our patients are asking. So I'm just going to go ahead and start asking them and just let everybody know we are going to go a few minutes over to get some of these questions addressed. So the first question is, in the overall Navigator population, you showed the ORR 22% and the clinical benefit rate of 41%, but then showed stable disease of 47%. Can you clarify, please?
Good question. Let me go back to the slide. Maybe I'm poor at math. That's a good question. I'll have to go look at where I pulled this from because the numbers don't add up right. So that is true.
Okay.
So I can't explain it offhand. I could try to shoot Sarah an email that she could disseminate once I figure it out. Obviously, I didn't notice that, else I would have presented the slide this way.
Not a problem. How can you know if cognitive symptoms are caused by one of the drugs one is on or if it's part of the aging process?
Well, that's a tough question, too. And so generally, for Avapritinib, since we've mostly been using it in advanced GIST, then we have, it's not like Imatinib where people could be on it for 10 or 20 years potentially, and so they age, during that time. Within the advanced studies, patient studies, we know what people are like coming in, or at least we know what their family thinks they're like coming in, which is the better judge. And so if we see changes that during the treatment of Avapritinib, which in most people other than the PDGFRA is less than a year, then we think they're due to the drug. We clearly saw in our studies that the higher the dose, the the quicker these symptoms came on and the more severe they would get if you didn't mitigate them. And so early on we were reducing the dose, and when we reduced the dose, we clearly see that people got better. So that would be sort of not the aging process, that was the drug process. We also saw that if you gave people 7 or 14 days off, they would get better, and sometimes they would go all the way back to baseline. So it requires some discernment. There also the question, which we don't really know the answer to, is, well, what if patients have mild cognitive impairment at baseline and we gave the drug, what would happen? And we don't know for sure, but I would be concerned that the symptoms might be more severe if you had cognitive impairment to begin with.
Okay, thank you. Somebody asked if you discussed how important mutational testing is, and I think everybody on this line or who's going to listen to the recording, you should be getting mutational testing. But I think sometimes people are confused with terminology. So somebody had asked if mutational testing is critical, is genetic testing also important or critical? Maybe you can help clarify some of those terms or further testing.
So, in genetic can be kind of a vaguish term. So in a classical sense, genetic testing would be, I'm testing your blood or your saliva. I'm testing what you inherited potentially to figure out, what you could pass on. So when we look at tumors, when we do mutation testing on tumors, we're actually looking, in the most cases, for things that develop. So patients weren't born with a KIT mutation, but the tumor acquired it, and that's what actually started the tumor. And so when I say mutation testing, I'm talking about tumor-directed testing. Sort of the blurred overlap is if you have SDH deficient GIST, then 80% of those actually are due to an inherited cause, and so we have to work backwards from the tumor to figure out they're SDH deficient, and then figure out what the mutation of SDH is. And then we have to test the patient's blood to figure out if they have the inherited type, and then we have to do genetic counseling to test more members of the family. So when I say mutation testing, I'm talking about, I should say, tumor mutation testing.
Okay, thank you. And another question further on that topic. Since Avapritinib is used with patients with advanced metastatic GIST and not surgical candidates often, how would one have mutational testing on a new growth showing up on a scan? And when's the appropriate time to do that sort of testing?
So I didn't repeat the first part of the question.
Since Avapritinib is used with patients with advanced metastatic GIST and not surgical candidates often, how would one have mutational testing on a new growth showing up on a scan?
So when I'm talking about mutational testing, I'm primarily talking about defining whether there's a KIT or PDGFRA mutations. What class of GIST do you have? That could be done on the very first biopsy or very first tumor. If you have PDGFRA D842V, you will have it always. If you have KIT exon 11, you will have that always. And so my kind of approach is that for any patient that I'm considering giving you a drug, whether it's after surgery, before surgery, or because you have advanced GIST, I want to know what your primary mutation was. Now, in the case of the second part of this question, I'm taking imatinib and it worked for 5 years and now I have a new thing in my liver, should I get that biopsied? That is complicated because what we know in most patients is that they have more than one drug-resistant clone. So where we biopsy can give us different results. Even across 10 tumors, there could be 10 different mutations. We're trying to figure this out, and we may get it from the Avapritinib and Ripretinib studies. We're trying to figure out how useful is circulating tumor DNA in predicting what's going on or predicting how we should change our therapy. We're not quite there, but maybe we will be in a year. At least we'll have some sense from these studies. In general, we don't do biopsies on secondary tumors because we don't really necessarily think it's helpful to what we're going to do next. But that could change. But even if it does change, I think circulating tumor DNA will be more useful than biopsying a new growth.
Okay, thank you. And also you had mentioned that resistance develops over time, so when would be the appropriate time to do molecular testing to look for mutations?
Well, if you have, as I say, if you have advanced GIST, it should have been done before you started imatinib. If you took imatinib after surgery, it should have been done before you did that. Because, for example, PDGFRA D842V, it will not respond to imatinib. Why take imatinib after surgery if it has no possibility of helping you? The same could be said of wild-type GIST that are resected. We don't really know that imatinib after surgery helps you. What we mainly know is if you have KIT exon 11 mutant GIST, after surgery, imatinib helps you the most. And so we would want to know that before we give you a drug.
I'm glad that you mentioned wild type because a couple questions came in about this. The questions are, what is the medication that would have the best likelihood to address those that have no known mutation?
Yeah, that is a tough question. So we don't think imatinib has much activity. I wouldn't say that it has zero, but I'd say that it has less than 10%. Some people would say it has zero activity, but I've seen a few people, but not many, who seem like imatinib did something for them. But the NIH and the wild type GIST clinic, those investigators feel that it does not do anything. Although I think they said 1 out of 50 people responded, so that's not zero. We believe that sunitinib is the most active thing we have for a SDH deficient GIST, which is the most common type of wild type GIST. There are studies of other things going on. Dr. Siklik is doing a study of temozolomide. There's other agents that were tested. We don't really know. One of the things that the LifeRaft group is helping to facilitate is this SDH consortium of multiple academic centers with expertise and interest in SDH deficient GIST or wild-type GIST more generally. And we're trying to run small little trials of 20 patients to test out, one drug at a time to see if we can find something that works. But, right now it's challenging. Personally, I think that serial surgery done carefully and selectively and thoughtfully might, to sort of reset the clock and buy us more time to come up with a medical therapy, might make as much sense as anything. But it's controversial, and if you had other GIST experts on this call right now answering this question, you might get somewhat of a different answer.
Well, appreciate you sharing your thoughts and opinion on that because I know that community really is interested in where we're progressing for that subtype. The next question is, are there any stats specifically regarding Ripretinib and exon 9?
I have not seen a breakdown of that from the phase 3 study. That will be forthcoming. In the phase 1 study, there were some patients with KIT exon 9 included. It seemed like it was active. There wasn't enough of them, I think, to have a differential idea, is it work the same as KIT exon 11 or not? So that data still needs to kind of, more people with KIT exon 9 need to, well, basically in Invictus, if we went back to the slide of it, there were how many people with exon 9? There were 16% of there were 20 total patients with KIT exon 9 in the study. So 14 of them actually were on the Ripretinib arm. So that's a reasonable number to get at least some sense, but they did not report the results of that yet.
And do certain primaries have certain mutations, such as is exon 9 most likely to mutate to an exon 13, for example?
Not necessarily. We believe that exon 9s oftentimes, because they're harder to drug, can kind of get through imatinib without a bunch of secondary mutations. But to get through sunitinib, they have to get secondary mutations. And to get through sunitinib, then they generally have to get exon 17 mutations. So there may be a little bit of biasing of mutations in the exon 9 space, but eventually they get all the usual mutations as far as we know.
Okay. There's a lot of great questions here, so I'm going to keep going.
That's fine.
What are your thoughts on off-label treatments or recycled drugs for GIST? Dog dewormer and other meds are gaining huge support in treating other cancers. And just so you know, these are some articles that are posting on some of these message boards. So I don't know if you've heard of all of them, but it's definitely, I guess, taking some traction on our message board. So any thoughts on that?
Obviously, repurposing drugs is of interest because those drugs have already been approved for something, and if we find that they have another use, it's easier to get them to patients. In general, we haven't really found that those things translate very well, and a number of groups, funded by the LifeRaft group have done things like this as well. And in general, the only drugs that kind of work that are approved are those that have some known KIT inhibitory activities. So I don't really think that things like worm treatments or things like that have any proven effectiveness. In terms of the more generic question of off-label, then prior to Avapritinib and Ripretinib, we didn't really. There's not an approved fourth-line strategy, but patients still need treatments, and so it would be quite common in the U.S., depending on your doctor, to get something else. I like Sorafenib. It has pretty good activity in the fourth line. Other people have used Pazopanib or Nilotinib. Axitinib has been used. Dasatinib.
Some people are also asking about immunotherapy. I don't know if you want to add that in or not.
Yeah. So, obviously immunotherapy is a new hot thing in oncology, but it should be noted that, we already knew before we got to GIST that many cancers don't respond to it. Even in the cancers that respond to it, what tends to happen is that a minority of people have this really super dramatic response. And so 20% of people have this fantastic, amazing response, and 80% of people, nothing happens for them. The immune system is pretty complicated. We only have a couple interventions that we can use. Dr. Singh, who's a medical oncologist at UCLA, did a study, a phase 2 study, in which he randomized people to either get nivolumab, which is, I think, Opdivo, versus nivolumab plus ipilimumab. And he saw, I think he's reported on almost 40 patients now that he treated. I think 2 of them had pretty dramatic, durable responses. And I would say that the other 38 or so did not have any meaningful response. And so the fact that 2 people respond suggests that, yes, there's something there, but the fact that it's only 2 out of 40 suggests that it's not ready to be used in that way. Dr. DiMatteo, who's now at Penn, has some pretty sophisticated mouse GIST models which have intact immune systems, and so he's been studying a lot of immune therapies in his models, and we're hoping that he will come up with something. But the agents that are approved do not seem to work for GIST, nor do they seem to work actually for sarcoma in general.
Okay, thank you. I'm just going to move on to a couple coronavirus questions, and then we'll close the meeting. So regarding testing for the coronavirus, would you recommend a home testing kit, which would then not require the protective gear being used by the testers? I know you had mentioned that earlier at the beginning of the call.
Yeah, well, if we thought it was reliable, I don't know if we've quite got to that point yet. So I guess if it was a reliable test, then sure, why not? I guess I haven't thought about that much, but
it's pretty new, so I think we're taking it day by day, right?
Yeah, hour by hour.
Right. One person said, I'm on imatinib and my neutrophil reading is 0.98. How concerned should I be about coronavirus? Have I got much of a chance if I catch it? I'm otherwise very healthy.
Yeah, neutrophils, which is what's measured if you're low, that's called neutropenia. Neutrophils are important for defense against bacteria. So if you have a very low neutrophil count, less than 500, then you're at incredibly high risk of getting a bacterial infection, generally from bacteria that already are in your mouth or on your skin or in your gut. We don't really think that would influence much, your immunity to viruses, which are defined by T cells and B cells, so other parts of your immune system. I guess if you got coronavirus with a low neutrophil count, maybe you could get a secondary pneumonia, but that doesn't seem to happen very much. So I would say probably not, but you should exercise the same caution as everybody else.
Okay, great. And this seems to continue. This was asked even after you answered some of the questions about the pain relievers, but it was if a GIST patient on Gleevec has a fever, well, what's the best course of treatment if I develop the symptoms, and what do you recommend? And they get listed, Tylenol, Advil, aspirin, Aleve. I think they're nervous about which one to make a choice on.
I think Tylenol is fine. Historically, as I said, we've said that don't use it if you had Gleevec, but that's based on like a few kids with leukemia and liver involvement by their leukemia who took Gleevec in the early days and Tylenol, and bad things happened. But I think bad things would have happened because their liver was being overrun by leukemia. In general practice, I don't really prohibit patients from taking Tylenol while they're on Gleevec. I just ask them to keep it, under 2,000 milligrams a day, which is either 6 regular Tylenol or 4 extra strength Tylenol. I personally don't think the ibuprofen thing is probably true, but it's out there, so I guess avoid that. Avoid Aleve for your fever because we have a choice. So hopefully that will sort of either be proven to be true or be debunked so that people would be less nervous about that.
Okay, thank you. I just want to share with everybody that the information provided in this seminar was not intended as a substitute for your physician's guidance and care, so please reach out if you have any individual questions to your physician. And we really want to thank Dr. Heinrich today because his presentation today was quite timely during this outbreak that he was able to spend some time answering some of your burning questions about coronavirus, but he also offered a really fantastic presentation on some of the new treatments out there for GIST, and it's great to hear from a leading expert. So thank you to everybody who attended. We had a large turnout. Thank you to Dr. Heinrich for your presentation. And any other questions that you may have, please feel free to reach out to the LifeRef group, and we'll do our best to direct them to Dr. Heinrich or to other experts and get back to you in a timely way. All right, and with that, everybody have a wonderful day.